Today I'll be talking about hoarding disorder. Hoarding disorder is a behavioral pattern characterized by an inability or unwillingness to discard personal possessions. These possessions accumulate to the point of cluttering living areas in the home and causing significant distress or impairment in adaptive functioning. There was a groundbreaking designation in 2013 in the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders that designated hoarding disorder as a psychiatric condition. Previously, in 2000, in the fourth edition, hoarding was listed as one of 8 diagnostic criteria for obsessive compulsive personality disorder. Hoarding disorder starts early in life. The onset of symptoms often presents in adolescence, beginning around the age of 13, with 60% of individuals reporting symptoms manifested before the age of 12. By 18, the percentage increases to 80%. Individuals with HD have vulnerabilities including challenging early life experiences and family influence. It's also a progressive disorder. This means that the symptoms tend to be chronic and continuous, and they can slowly increase over time with each decade of life. It also is not a disease or disorder that remits if left untreated. Possessions hinder everyday functions. Possessions overflow the living space and hinder cooking in the kitchen, sleeping in a bed, or even sitting on a sofa. And the emotional attachment to stuff is unrelenting. Prevalence rates include the fact that 2 to 6% of the United States population has HD. Rates are similar in both men and women who meet the criteria. And 25% of older adults present with hoarding behaviors several times a week or higher. 62% of individuals with HD have comorbid major depressive disorder, while 32% have generalized anxiety disorder. The impact with individuals with HD are on the individual, family, and community levels. Individually, there are cleanliness issues that can result in unhealthy or unsafe conditions. Legal problems, including eviction, strain on personal relationships and the outside world, feelings of embarrassment, isolation, loneliness, depression, and an increased risk of injury and accidental death. On the family level, members may resent HD, they may feel hopeless, or they simply may feel sad that they do not know how to help. On the community level, we see an increased risk of fire, damage when fires do occur, and a disproportionate number of fire-related injuries and fatalities. There is a significant burden on social care services, public health, and systems surrounding individuals with HD. As far as interventions, the effective interventions are few. Pharmacology is an area that is not deemed efficacious at this time. There are no medications that are currently FDA approved for treating HD. On a psychotherapy level, cognitive behavior therapy is the gold standard of care for those with HD. However, compared to other future promising treatments, it is not as effective as one would hope. Then there's CBT for HD specifically, as well as group peer facilitated therapy, and something we'll be talking about next called CREST. As a level D, the promising interventions include SSRIs, SNRIs, as well as other treatments such as augmented buried in treasure and acceptance and commitment therapy, as well as rational emotive behavior therapy, which is an old form of cognitive behavior therapy. On the level C, we have additional SSRIs that have been studied, as well as central nervous system stimulants and ADHD pharmacology, including SNRIs. For the level C psychotherapy, we have many upcoming promising options that need further studies, including social cognitive and intervention training, virtual reality discarding, compassion focused therapy, which we'll be discussing today, as well as a few others that you can see listed here. Let's start with CREST. CREST stands for Cognitive Rehabilitation and Exposure Sorting Training. This was specifically designed for older adults, including veterans. It's perceived to be highly effective by the participants themselves, especially for relapse prevention, which is high in cases of HD treatment. It addresses neurocognitive weaknesses by using compensatory cognitive training to improve executive functioning and cognitive weaknesses. It targets the core symptoms of urges to save and avoidance of discarding that lead to the accumulation of clutter by using behavioral exposure to the distress of discarding and not acquiring. There have been consistent results with multiple randomized control studies on older adults made with this intervention, which is a level A. In a randomized controlled trial, participants who received CREST had higher response rates to treatment and greater improvement in hoarding severity, as well as activities of daily living and general anxiety from baseline to post-treatment. Other positive outcomes: no reversal of treatment gains for 6 months following post-treatment assessment, and increased treatment gains in older adults with hoarding disorder when compared to geriatric case management. The way that CREST works is that it's a 26 weekly, 60-minute individual sessions for 6 months. And each of these skills are targeted to have the best possible outcome. Intervention 2 is compassion-focused therapy. This is a therapeutic treatment that views HD through the lens of compassion from Buddhist philosophy. It focuses on seeing and understanding how suffering occurs and being willing to help. Interestingly, this is an intervention that focuses on the self-compassion, self-worth, self-hatred, and self-criticism. It also focuses on blame, and we learn how to shift the blame away from oneself. And negative emotions. We learn to regulate our negative emotions that may arise in response to cognitive restructuring attempts. There is a lot of supporting evidence, even though there still is work to be done. Multiple studies have found that CFT techniques, along with CBT programs, result in greater treatment effects than just standalone CBT. Alternatively, there's promising potential of CFT, particularly for those who do not respond well to CBT. 77% of participants have had severity scores below the cutoff for clinically significant hoarding, and 62% of participants achieved a clinically significant reduction in symptom severity. In conclusion, I'd like to discuss the knowledge gaps. The state of science. There are potential barriers to the successful treatment of HD, including awareness of the availability of and access to treatment, patient motivation, and insight. We need to study more. Virtual reality discarding is promising, but there are not enough studies as of today. That's true also of biological interventions, which we have a chance to help people with HD further. Thank you so much for listening, and have a wonderful day.